Good morning and good afternoon. Thank you very much. Good morning and good afternoon. Thank you very much for joining our second webinar series. And this one is titled Hematology Potpourri. And hold it for a second. Okay, can bring the screen up. And so basically, it's going to present a whole bunch of case studies. And I'm sorry we have lost a few minutes in getting the technology fixed up first. And so the case one would be a 61-year-old male presented with fever, night sweat, and dry cough. So initially he thought he had a cold, and because the night sweat was bothering him, so he went to see the doctor on day 6 with a temperature of 38.6. And he looked pale, and his eye, the white of his eye, is slightly yellow. And the CBC was ordered, and then coagglutinin was noted on the smear. On the pre-warm sample, the CBC is with the WBC of slightly decreased. There's some labs may even call it normal, but unfortunately the neutrophil looks like it is decreased. The lymphocyte count is normal, monocyte and basophils are normal. And the hemoglobin is 75 grams per liter, or in another unit would be 7.5 grams per deciliter. MCV is normal, platelet is normal, reticulocyte count is slightly on the low normal side. And because of the coagglutinin, so the DAT was ordered with a C3D positive, and somehow a monospot was also ordered with a positive result. It's interesting because this is happening in a 61-year-old, and I'm not sure why the physician want to order a mono test to start with. But nevertheless, it turned out the mono test was positive. So the working diagnosis at that time was autoimmune hemolytic anemia with coagglutinin present. And because of that, because there's no unknown reason of the autoimmune hemolytic anemia, a bone marrow was ordered, and bone marrow aspirate and biopsy was done. So while I am, okay, good. Now, so look at the peripheral blood. Definitely there's coagglutinin, as we have described in the last slide. Definitely there's neutropenia because you don't see neutrophil on this slide. The platelets are normal. There's one lymphocyte there. And so the coagglutinin is small clumps. They're not big chunks of coagglutinin. And that's why the MCV is still relatively normal. And so from the bone marrow side, when we assess the bone marrow, we generally start off with the bone marrow aspirate, looking at the push film as well as the squash film, and then look at the biopsy slides. And if it's warranted, then we'll use the biopsy slide to do the immunohistochemical stain, and also use if it is necessary, we also use the bone marrow aspirate to do some flow cytometry as well. So cellularity-wise, the first thing we look at on the aspirate is under low power. Under low power, look at the cellularity. It's about 60%. The second thing we look at is ME ratio. ME ratio means the myeloid to erythroid ratio. In a normal bone marrow, the myeloid to erythroid ratio generally is about 3 to 1. That is about 3 myeloid cells, including the early myeloid cells, to 1 erythroid cells. So this is a typical example of a not ME ratio of 3 to 1. So this is about 20 to 1. There are lots of there's some red cells, but these red cells are early red cells. You should be able to see some most of the red cells should be late stage instead of the early stage. In this case, there's some, like this red cell is very large, and also with large nucleoli as well. And the maturation of these myeloid cells are decent. They are not affected. You see some neutrophils, a myeloid element here, and then a band cell here, a myeloid cell here. Interestingly, in our lab, when we look at the peripheral blood, we don't count band cells. We count them as neutrophils. But in the bone marrow is that we do count the band cells as part of the differential. So again, this is a metamyelocyte. So this seems to be well represented in that sense. But if you look at a higher power, again, it reflects the same thing. There's sufficient myeloid elements, but the erythroid elements are suppressed due to we don't see a lot of late-stage erythroid cells. But we do see some early stage, such as this guy, and we do see a megakaryocytic element right here. And the rest of them are literally all myeloid cells, or most of them myeloid cells. So there's early red cells, and there may be even a blast cell here. And these are the myelocytes and metamyelocyte, that type of thing. So if you look at the general picture, unfortunately, 1 or 2 slides generally cannot tell the whole picture. But you look at it under the microscope, believe me, the myeloid to erythroid ratio is 20 to 1. Interesting in this bone marrow is that as we scan the slide, there are lots of these guys here, naked nucleus with very prominent nucleoli, and so lots of these granular structure inside this naked nucleus. And this naked nucleus reflects on this degenerating cell, which shows a little bit of cytoplasm and same granularity with a little bit of nucleoli, something in there. So we call it, this would be the naked nucleus, and we call this a nuclear inclusions. So we saw a lot of these cells. I wish I could show you a virtual slide, then I can demonstrate to you how many of these naked nuclei are there and how many of these huge cells are there. And these huge cells actually are corresponding to the large early normoblasts that you saw earlier. So I will go back to the bone marrow slides in a bit, but let's go back to the serology we also order. Because of these large cells that we saw, the physician suspect the patient may have parvovirus B19 infection. So that the test result came back with parvovirus IgM, which indicate recent infection and is reactive. In other words, the patient have a recent infection of parvovirus B19. IgG, which indicate past infection, show that there's no reactive, it's not reactive. So in other words, the patient never had a parvovirus B19 infection. EBV virus, IgG, again, IgG shows past infection, is reactive. CMV, reactive. HIV, non-reactive. So this panel of serology telling us that the patient have IgM, telling us the patient have a recent infection of parvovirus B19. Now, I'm going to tell you a little bit about the parvovirus B19. It's also known as the 5th disease. The reason it's called disease number 5 or 5th disease is because it's named after we discovered the 4 childhood diseases, which is measles, rubella, chickenpox, and roseola. Then this 5th disease came along in 1974. And in 1974, when someone was testing a batch of serum samples for hepatitis B, they discovered one single sample in panel B, the sample number 19. It shows a very strange testing pattern, which is not the same as the hepatitis B surface antigen testing pattern. So as a result, they've gone through some further testing. They keep the sample aside, and in 1981, parvo B virus was linked to a transient aplastic crisis in patients with sickle cell anemia. It's very interesting in that sense because remember, when we talk about the parvovirus generally infect early erythroid cells, resulting in erythroid cells maturation arrest. So when you think of a patient who has sickle cell anemia, when they go through a sickle cell crisis, the cells are already being damaged. In the bone marrow, there's not enough cells, not enough red cells to mature to a stage where they can push out to the peripheral blood to compensate for the sickle cells destruction. So as a result, there will be a transient aplastic crisis, meaning that patient's hemoglobin will drop, reticulocyte count will drop, which I'll show you in a graph a little bit later. So it looks like aplastic anemia, but actually it's a transient form of aplastic anemia in this sickle cell crisis. The parvovirus life cycle is no different than the viral cycle in other viral infections. You start off with attachment of the virus onto the host cell, and the virus is being released, virus duplicated, and as a result, virus is the cell will lyse, and the virus will be released into the host cell and infect more host cells. As a result, there will be a more maturation, arrest of the proerythrocytes. The transmission route generally is through respiratory, in other words, coughing, drops, and blood products, albumin, IVIG, fibrinogen, mother to fetus, among lab staff who handle virus even. So, because of that, you can, most patients generally, they are not affected clinically, but they do have immunity. So as a result, children generally who are not exposed to the virus when they're young, you will see them being infected in the school-age children. You'll see sometimes in daycare workers and homemakers. And it's particularly, you can see a peak infection during the springtime and also during the wintertime. In other words, the whole symptom of the infection, it's just like your cold virus, except the symptoms are slightly different. So the biphasic clinical phase would be the first week, about 7 days after infection, you see fever, chills, weakness. About 2 weeks after infection, 2 to 3 weeks, you see a rashy skin, particularly in young children. The rash actually starts off in the cheeks. That's why we call them the slap cheek syndrome. Looks like the child's cheeks have been slapped. As a result, turns red, and the skin can turn itchy. And the IgM antibody, if you look at the serology, also shows a biphasic change. IgM antibody showed up first, which indicate current reinfection. IgG antibody showed up later, will last for a lifetime. So that's the graph that you should see. And about 7 days right here, when the viremia count peaks, will coincide with the first symptom, fever, chills, headache, and stuff like that. And about 3 weeks, 2 weeks to 3 weeks, rash, and and then same thing with the the viremia count actually subsided after 14 days, and then IgM will go up, last for about 3 weeks to 4 weeks, and then subside. IgG will start to rise in the second week, and then will continue on and then stay with the patient. In healthy individual, generally is asymptomatic with subclinical features. Children 18 days post-infection, as I said, fever, headache, and all that stuff. Adult actually will suffer joint pain as well. So for people who are pregnant, can severely affect them because it can result in abortion, stillbirth, hydrops fetalis, and also present as congenital anemia. Interesting fact is that the virus seems to like cells that have P positive antigen. So patients who are negative for P antigen, they will not get infection. And there are other co-receptors that are involved, but we don't have to understand that which other co-receptors may be involved. Excuse me. And one interesting fact is that the B19 is shown to agglutinate human RBC in vitro. So that led to the speculation that when we do, let's say, infectious mono test, which require hemagglutination test, it may show a false positive result in some tests. So these giant normoblasts or pronormoblasts, it's also been described as lantern cells because a big nucleoli inside looks like the lantern, the candle of the lantern inside. And you will see these nuclear inclusion bodies, especially under electron microscopy. As I mentioned, you should check your infectious mono test kit to make sure that they are not affected by the parvovirus B19. Because when this patient came along, the patient was monotest positive, remember? So we went back and looked at the package insert. It did say that can cause positive results if patient have parvovirus B19. So make sure you go back and take a look at the pamphlet insert. So let's move on quickly to case number 2. Patients presented with pancytopenia and large spleen and abnormal liver function. And because of the pancytopenia and large spleen, definitely will require some follow-up the suspicion at that time was myelodysplastic syndrome and a bone marrow disorder. Peripheral blood-wise, white count is 2, and hemoglobin is not too bad, even though for male it's supposed to be about 135 or something. And the MCV is normal, platelet count is definitely decreased, retit is normal, and the rest of the differentials seem to be normal, except that there were occasional myelocyte early cells, and also there's something called other cells, which is turned out to be some sort of cells like this. Looks like a blastish looking cell. There's also NRBC present peripherally. You notice that there's no platelet count or very small number of platelets on the peripheral blood, and the rest of the peripheral blood seem to be okay. Now, looking at the bone marrow again, when you assess bone marrow, always assess it systematically. Look at the cellularity, look at the ME ratio, and then after that, you look at, are there any maturity issue? In other words, are the myeloid cells maturing okay? Are the erythroid cells maturing okay? Are the megakaryocytes maturing okay? Every cell line to be assessed properly. And after that, then you also have to look at, are there any that doesn't belong to the bone marrow? So when we look at this patient, we notice that, there are a lot of erythroid cells, it seems. 1 here, 3 here. This one is abnormal because it's double nucleus. And this is also a erythroid cell. There's also a erythroid cell. Remember, ME ratio normally supposed to be 3:1. If you do a quick count of these so-called cells, nucleated cells, there's definitely a lot more red cells than the myeloid elements. And of the myeloid elements, you'll see some of these large blottish looking cells. You'll see this one looks like, I call it the dog's ear. It looks like these 2 protrusion blebs of cytoplasmic blabbing. And also there's some cells that looks like they're like this with granules inside, but the granules are not distributed evenly. Same as here, it looks like the cells are sort of destroyed, and also there's some granule inside, and then some cells here as well. So the next slide will give you a better picture. This cell, again, as I said, the cells here, the granules are here, not evenly distributed. And same here, some of them are mononuclear, some of them binucleus, and same thing here, there's some of the blastish looking cells, and these ones are this one is binucleated, this one is sort of binucleated, and the granules are getting larger than some of the other ones. So same as here. So lots of these cells, initial look at it, looks like they are, maybe someone may even call it myelocyte. But when you look at it closer, the cell that comes to mind would be, or could this be basophils? Because basophils generally can look like that in the peripheral blood too, except they can be washed out as well. So in this case, it's just like, it looks like a washed-out basophil. So there's mitotic figure here. There's also an early cell, could be an early red cell, and definitely there's a blastish-looking cell. So looking at that, because of these cells that are here, it is quite concerning. The cells that have granules in there, because they are not truly myeloid elements. You look at the peripheral, when you look at the biopsy itself, the biopsy, for those who are not familiar with looking at biopsy, generally we don't look at the biopsy with high power. We look at biopsy with low power. In this case, in the low power, this slide is about 4 times 4 times 4 times 5. This is about times 10. So you look at this, you don't look at the cellular detail in biopsy. Rather, you look at the change in patterns. So in this case, there's a homogeneous pattern of something here. There's also slightly different here. Look at staining patterns. It's more dense cells. There's a little bit more very, very funny looking cells. This slide is the same. It's a blow up of this area here. You notice that these are very, very mononuclear cells, and some of the cells also what I call them spindle-looking cells. So this one almost looks like muscle cells, fibroblasts even. So this one, this one, this one. These are actually abnormal mast cells. Mast cells is a tissue form of basophils. So when you look at the bone marrow, we decided to do a immunohistochemistry, which I'm going to pass this to Samantha. She is expert in flow cytometry. You have to excuse me for a second. And she is going to talk a little bit about the bone marrow staining, the flow cytometry of mast cell leukemia, which in this case, we suspect it is mast cell leukemia. So I will, hold on for a second. I'm going to pass the road to, which one are you, Samantha? Okay, hold on for a second. So Sam, which one are you?
Let's see. I think I was 14 actually.
14, okay.
Yeah.
17, 8. Why don't you try? Can people hear Samantha?
Yes.
Okay.
Okay, I can just talk real fast.
Let me just talk, sure.
Okay. For mast cell leukemia, the leukemic cells are usually positive for CD13, 33, 68, 117, and they usually express 2 and 25, which in this case we had 117, 68, 2 and 25, which is kind of that's very characteristic of mast cell leukemia. They are not positive for basophil markers, so they'll be negative for 11B and 123, which is what you would expect to see in basophils, and they're also negative for the monocytic markers CD14 and 15. In a reactive case, if you had mast cells or basophils that were reactive, you'd expect to see CD63 positive, which in mast cell leukemia, they'll be 63 negative. But if it was a reactive case, you would see the 63 positive, which is one way to differentiate a reactive versus a malignant mast cell leukemia. And another way to differentiate between a reactive case is that expression of CD2 and CD25. If this was a benign case, you would not be CD2 and CD25 positive. Another thing with mast cell leukemia is the overexpression of the an anti-apoptosis gene, the BCL2. That is not going to be positive in a benign or a reactive case. CD117 is usually expressed in AML, and it's a marker for immaturity. So that wouldn't help too much with differentiating mast cell leukemia from a typical AML, but it is usually positive in mast cell leukemia. But really what's going to help differentiate this from AML in general is that CD2 and CD25, because you would not expect to see the CD2 or the CD25 positive in AML, and that's something that is very specific for mast cell leukemia.
And the tryptase is important.
Yes, tryptase is very important. That's not, it's in the granules. That's not something we'd usually like stain for in flow, but that's extremely important.
Good. Okay, thank you, Sam. So,
thanks.
Okay, let's move on to the next slide. I'm going to just unmute everybody first, so we won't give you a background noise. Okay, so mast cell leukemia, so the mast cell actually is derived just like other hematopoietic cells. It derived from hematopoietic progenitor cells, and they circulate in the blood. That's why you see them as basophils, and will generally migrate to skin tissues. And the skin tissues generally are in airway, skin. The tissues are generally in airway, skin, and intestine. And it's activated by pathogens such as bacteria, virus, fungi, parasites. And once it's activated, and it will release these granules and help with the defense mechanism of the host cells. Now, a general category of malignancy called mastocytosis is a heterogeneous disease with abnormal accumulation of mast cells in different organs or different parts of the body. WHO classification of mastocytosis divided into 7 categories. The first one is a cutaneous, the other one is indolent, the third one is a long name called systematic mastocytosis with an associated clonal hematologic non-mast cells lineage disease. It's a long name. When they say clonal hematological non-MC lineage, we're talking something like hematological diseases generally have, you can see a lot of basophils perhaps, and so such as CMMOL. So, and there's another form called aggressive systematic mastocytosis, which is in contrast with the indolent form. And of course, the worst, not the worst, but also another form is the leukemic form, which will infiltrate the bone marrow. And then there's mast cell sarcoma, as well as extracutaneous mastocytoma. And we're going to focus on the mast cell leukemia, which is in this case is. And it can happen as a de novo or secondary disease. Actually, I actually have another case, which I'm not going to show here. Actually start off with, I believe it is a myelodysplastic syndrome, and then eventually evolve into a mast cell leukemia. It's a very, very rare form of disease, and yet it's extremely aggressive, because generally patients who have this disease, they will not survive more than 6 months. And the bone marrow, peripheral blood, you can have a 10% mast cells or basophils, but definitely the definitive criteria is you need more than 20% of mast cells in the bone marrow. And in terms of those morphology, it can vary from the mature form to the immature form, as I have shown you earlier, and also show you on this slide here. And initially, it could look like this. The granules are evenly distributed, and then later, you can see the granules start to coalesce together. In other words, they stick together and form larger granules. And then this more look like a basophil, and you can have a pro-mast cells look like this with nucleoli, and this could be a blast cell. And when you see something like this on a mast cell with binucleus, that's not very normal. And same as this, so what I call the spindle shape, a mast cell that is all stretched out. So which I show you in this patient, a mast cell, a binucleated mast cell, and this one is sort of slowly dividing into two nucleus. So quite a few of these abnormal looking mast cells in this patient. And okay, same thing here. There's some blast cell. These are probably eventually, these are blast cells of the mast cell series, same as these ones. These ones are, this may be a erythroid cell, and this is abnormal, binucleated. And this is a red cell, and also a blast cell here too. Again, spindle-shaped mast cells resemble fibroblasts, like here. So actually, this whole sheet, they are mast cells, except this along here, you see the spindle-shaped mast cells. So case 3, we quickly move along, is I posted this case probably in the beginning, in December last year when I first formed the HIG group. So this is a young child, 6 months old, with the parents were concerned because they saw blood in the child's stool. And so the history tells us that the child was breastfed since birth. And the patient also have a lot of eczema, diaper rash, so there was concern maybe allergic to dairy products, and so the mother was advised to put the child on soy product and give it a try. The birth weight was normal, and the child had sores in his throat and resolved with antibiotics. And he also had folliculitis on the abdomen, also improved with antibiotic because of the eczema, putting on some cream, and it seemed to help a little bit. The older brother has asthma and had bloody stool episodes as well, but eventually was resolved. The aunt also had eczema. They also had a dog in the house. That didn't help because if it is some sort of allergy, the child could be allergic to, the pets in the house. And there's lots of scratch mark on the child's scalp, probably because of itchiness. And the diagnosis at that time was that, children get allergies all the time. So maybe allergic to dairy products and maybe allergic to soy products too. So it was prescribed Benadryl, antihistamine, all the stuff that helped the patient, to treat allergy, and suggest to do the allergy testing when the child is 1 year old. The family history-wise, the patient was from Dutch ancestry. There's no known consanguinity. In other words, just in case there's consanguinity, sometimes there's lots of abnormality can pass down from this kind of marriages. The pediatrician also noticed that the patient had partial albinism, and also when check his eyes, there seemed to be some photosensitiveness on his eyesight. White count is 11, hemoglobin is 117, and for a child that's young, 5 or 6 months old, generally it can be a little bit higher, but nothing too concerning in that sense. And neutrophil 2.1, number-wise, the patient is fine. Morphology on the red cell side is normal. When you look at the peripheral blood, there are these cells here, the neutrophil, that have these large granules. Remember the last case I showed you are the basophilic granules. This is different. This is the last case I showed you, basophilic granules in parvovirus. The first case was parvovirus, the second case was mast cells. This one is not. This one is, these granules are very different. They are in the mature neutrophils. And there's also a cell here, I'm not sure what this is. It could be a lymphocyte with some vacuoles in there. It could be a diane cell, pigmented cell as well. Bone marrow, definitely. There are lots of large cells. Sorry, but the color is not quite right, a little bit too blue. But there are lots of large granules here. And it's showing this could be a monocyte, and this is a myelocyte. And this is mature neutrophil. Looks like there's some eosinophilic granule, but the granules are way too big. Same as here. There are lots of granules. And I was not able to demonstrate to you these granules in lymphocytes. So the diagnosis after seeing all this is Chita-Higashi syndrome. And typically the clinical syndromes they happen because it's genetic disorder. So there's mucus, there's respiratory and skin infection, and because it affect basically the abnormality affect a lot of cells, including the skin cells, including the eye, including the hair follicles. And so as a result, the patient could show oculocutaneous albinism affecting the eye, the skin, and the hair. And there's not much you can do about the disease itself. Generally, it will progress to a lymphoma-like syndrome. So if I believe that this patient actually, when I look at his squash film, looks like there are quite a number of lymphocytes there as well. And the diagnostic feature would be large granules in the leukocytes of all cell lines. It's a genetic disorder, and the gene affected is called CHS1. It's autosomal, the recessive disease, and affecting how the protein is transported from in and out or within the cells or outside the cell as well. And resulting in abnormal lysosome and storage granule abnormality in all leukocytes, in platelets, fibroblasts, and also skin cells, the melanocytes. So because of this, the white cells are not able to fight infection. Patient will have recurring infection, bacterial infection. And when you do a bone marrow, you can sometimes see hemophagocytic lymphohistiocytosis, HLH, which will be totally different some other time. And as I said, it can progress to lymphoproliferative lymphoma-like disorders. So let's wrap this up with case 4. Clinical history is that 26-year-old male with some neurodegenerative genetic disorder from childhood. So the patient has been cared for by the dad because the parents were divorced. So the child looked up this young man, now is 26-year-old. And the father noticed that this young adult has decreasing consciousness. Obviously, this patient, the 26-year-old patient, it's not totally competent in looking after himself. The father had to look after him. So he brought him. The father took him to ER because of decreasing consciousness. And on admission, the white count looks slightly increased. And you look at the CBC panel, the hemoglobin is very abnormal, 14 grams. In other words, 1.4 grams, which is the lowest hemoglobin I've seen. Some of you probably have seen something is lower than that, but this is extremely, extremely low. The MCV is only 54 femtoliters. MCHC noted is 246 grams per liter. Again, it's extremely low MCHC. Platelet is normal, retit is decreased. So the first thing when you see a sample like this, because of low hemoglobin, the first thing you would do is check and make sure is the sample diluted? Is it possible that such a low hemoglobin? So check the sample and see if it is diluted. Is it contaminated with IV fluid? Is it clotted? And also you potentially you can ask for ER. Hey, what's happening here? Is there a mistake made here? And ask for a recollect. And that's what we did. The patient, there's no problem with the patient. The sample looks definitely show. There's no problem with the sample either because the sample is collected properly, and there's only a little bit of a button here. And you notice that the hematocrit actually was very low. The hematocrit was 6. It's only 6%. We report at 0.06. So not only that, the plasma generally is supposed to be slightly yellow, but in this case, it's extremely clear. Almost look like it is a contamination, but it is not. So look at the peripheral blood. Definitely, there's some problem here. The white cell, there's enough neutrophils there, but there are lots of hypochromic microcytic cells, and there are not too many cells there either. So which confirms that the patient is extremely anemic. Higher power. There are some hypochromic macrocytic cells. Lots of these are microcytic with target cells, and occasional schistocytes as well. So sometimes when we see schistocyte, we automatically assuming that it is due to MAHA, microangiopathic hemolytic anemia. But in this case, it's not because it's not due to microangiopathic problem. So in this case, it is as you can see from the chemistry side, the iron is very low. The TIBC is low. The TIBC is high. In other words, there's not many iron for it to bind, as a result into lots of binding capacity. Fraction saturation is extremely low. Folate also is interesting, is very, very low. So the diagnosis at that time, just because of low iron, and we just slowly give the patient some iron, some red cells over 4 days. The hemoglobin comes back to 90 grams, and so the patient comes back to normal. Of course, we still have to deal with his iron status, we still with his folate status, but we did get the patient's hemoglobin up to 90 grams. So because of low MCHC is a constant problem in some instruments. So when hopefully your lab will have some protocol in dealing with high MCHC as well as low MCHC. Remember, in this case, the MCHC was only 24, 25. So we have to realize that hypernatremia, hyperglycemia, or anything that causes osmotic imbalance can cause your MCV to be falsely elevated or falsely decreased, and then resulting in your MCHC also is abnormal as well. So make sure that your lab policy cover hyponatremia and hypernatremia and hyperglycemia cases. This would be a typo here, not hyponatremia and hypernatremia. In this case, the patient actually the sodium was only 125, I believe, about 125. So that's all the 4 cases. I'm going to give you a quick snap on a few other cases, but just one single slide. So in this case, you can see a this is a peripheral blood. Okay, there are not too many red cells, there's nuclear red cells, but there are lots of gold cells all around. In this case, it's a hemolytic anemia caused by the Clostridium infection. So lots of cells are being lysed. The patient actually died within hours. I did not have a slide that showed the bacteria, but I forgot to put that up because we could see the bacteria actually in the patient's blood. So second slide I want to show you is this is definitely a leukemia because these cells are very early, and also some of you have picked up this is a promyelocytic leukemia. This is a single owl rod right here. The specific feature is folded nucleus, and this is APL. This is another APL with a different feature. This one in the bone marrow, you can see beautiful owl rods. Even this fragmented cytoplasm are shattered off. It's lots of bundles of owl rods everywhere. Beautiful APL cell. This one is interesting because this is from a patient with beta thalassemia major with multiple transfusion support. You can see NRBC everywhere, and also you can see papillae bodies. Papillae bodies are iron, basically iron deposit, because due to the multiple transfusion, and there's lots of papillae bodies everywhere, and polychromasia because the body is continuously trying to compensate for the abnormal hemoglobin. So this one is beta thalassemia major with transfusion support, and this one is this one is interesting. This one is it looks like it's lots of spherocytes. You're right. There's lots of spherocytes. These spherocytes are microspherocytes, like this one in the corner here, this one here, and this one is from a burn patient. This patient was from a plane crash, and the patient did not survive. It's a very sad case. So the patient came to our hospital, and both patients die, plus a number of patients suffer severe injury. So that wraps up our 50 minutes of case studies, and I want to ask if anybody have questions, but I'm going to unmute you first, and also need to stop recording.